Hello. Can we try and settle down somewhat so we can get started on our next keynote session? And I'm Dr. Damian Milton, and I'm here to proudly present to you our next keynote speaker, Bernadette Grosjean, who's an autistic psychiatrist who's now retired but has been working for many years and going to be talking about what they've learned as an autistic psychiatrist inside the profession, which, as the title suggests, has its own somewhat checkered history in this area. So without further ado, because of timing, I'll hand you over to Bernadette.
Thank you so much, Damian. And it's so fitting that you introduced my talk, because as you will see, you're part of it. Thank you to Autism Europe, to AsIAm, Dublin, for inviting me here. I want to also have a special thank you for all the staff and volunteer. You make me feel safe. You make me feel understood, and it's not always the case in gatherings like this, so thank you so much. Working together. As Damian Milton reminded us, our innate ability to fully apprehend one another is limited by our own experience and neurology. This is particularly relevant when it comes to understanding one another across neurotypes, non-autistic versus autistic, because of our differences in ability to connect and to communicate. Being able to grasp, but more importantly, to believe someone when they are different from us, be their sex, age, ethnicity, or neurotype, is crucial when it comes to quality of life and care. It can literally be a question of life or death. The first part of this talk is very personal. I'm using my own story because I realize that most neurotypical clinicians' knowledge comes from their outdated perceptions of autism, with emphasis on deficit, rather than from exposure to autistic people's experience and narratives from the inside, the good and the bad, the struggles and the strengths. This is one story, unique in many ways, but in many other ways quite typical for a number of autistic people. I will show how my neurology impacted my journey, but also my work. So working together. This did not come to me spontaneously. Not because I did not want it to work or play alongside others. I could have used the help and the fun. I just did not know how to do that together thing, in particular when it came to asking for help. I did not know how to ask, what to ask, how I could be helped, what I needed help for, or how to see that others needed help too. I learned not too long ago that for someone like me who is autistic, struggling to ask for help was typical, or more precisely, atypical. I was lucky enough, I suppose, to be smart enough, strong enough, and driven enough that I managed on my own for a long while in the place where it mattered, school, at least for what was assessed there, the facts that we were taught. Nobody was testing my social skills. Helping others, on the other hand, even if I did not immediately understand how it was done, was something I wanted to do very early. I grew up in Belgium in the 60s, listening every weekend to conversations about the war. At 7 already, an avid reader, I found in the attic magazines about the war my folks were talking about. Beside the pictures of battles and tanks were the devastating images of the death camps like Auschwitz or Ravensbrück. I still see to this day the pictures of Nazis' experiments on children. I understood very quickly that the world was a dangerous place. My early sense of justice and our duty to relieve the pain of this world came at the same time. At 7, I wanted to become a doctor. At 12, a psychoanalyst. At 13, I was involved with Amnesty International. But how to care for others? How to change the world when you don't know spontaneously how to work together with others who seem so different from you? Believe me, in elementary school, there were no other kids with whom I could share my horror of Ravensbrück or my excitement about French philosophers. I did not know how to work with people because I did not know how to connect. I tried. I did not understand why I was so clumsy. I did not get people, feel them. I did not have the language, the tools, the facial expressions, the superficial chit-chat, which are passwords for social recognition. I was too much or not enough, too smart, too sensitive, too demanding. I was feeling too much, reading too much. I was not girly enough, not funny enough, not present enough. I was hopelessly on my own. Alone, not because I wanted to be, although I needed solitude at times. I did not know how to be someone else, or at least pass for one of them. I did not have the mask and the costumes. I was sad but okay because I had nature and I had my books. Books were my key to the world, my loyal friends, my refuge. With them I felt safe. The writing would not change from one day to the next. I was in charge of our routine. They were full of stories, civilizations, landscapes, and mysteries. There were no surprises except for the content of the book. And if I did not understand, I could go back, take it slow. If it was upsetting, I could skip over and come back later or not. Books were my friends, familiar, predictable. They never let me down and always gave me time to process whatever they were triggering in me. The books gave me models for socialization, helped me to understand what was going on inside people's minds, as did my endless observations of the world I was living in. I learned some of these keywords, tried to smile more, to play with others, and put the cool kid's mask on. Looking back, it must have been excruciating at times for me and for the people around me. My real way to connect was to help. In high school, I was on all the student association boards and not afraid to advocate for my comrades. Some appreciated, I got a few thank yous, but also, of course, pushbacks and bullying. Potential friends, moved by my clumsiness and good intentions, tried to take me under their wing, but then, suddenly, the contact would be lost. I could never understand why. I did not know spontaneously basic rules like taking turn in conversation, showing interest in others' chit-chat with my face or regular hum and haw. I could talk about the history of the Russian Revolution for hours. It was my special interest at the time, and I was not sure why people were not more interested. As a teenager, I had no clue about what was the center of my girlfriend's attention: boys. I did not get it at all. In my last years of high school, it was dark. I was more lost than ever and down. I was asked time and again to put a smile on my face. I was not sure how to do that, but I tried. I put my head down and kept studying and observing and reading and searching and tried to make sense on my own. I did not know how to collaborate with schoolmates. I did not see their frustration or did not know how to address it. I also rarely saw when someone was using me. It was nice to be wanted, ever for a brief while. Early in medical school, Someone asked me why I was equally nice with everybody. He definitely was not. And why I was apologizing all the time. It took me 40 years to answer that question. I now understand that it was the consequences of decades of walking blindfolded in social context and a lifelong experience of abrupt breaks in connections, of people being suddenly mad at me and me having no idea why. I was ashamed, embarrassed. I took that something was wrong with me, so just in case, I apologized. After an episode of severe depression in my 20s, I started therapy. For 6 years, twice a week, and for free, thanks to the wonderful Belgium healthcare system, I learned the healing power of being given time, being trusted and heard, of being able to share and feel, the power of validation and of working together. My therapist helped me to identify and make sense of my feelings, how to imagine the ones in others, how to better communicate, why it was important to take turns and return calls. Finally, someone was working with me. What an experience! A first bridge towards the world around me, like having access to a living dictionary that helped me learn the multiple meanings, not only of words, but of nonverbal signals. The cues that most everybody else got apparently so easily just by being born in it. While I was experiencing firsthand the miracle of interpersonal therapy, I was training to become a physician and learned both the powers and the limits of our art. It was the mid-80s, at the height of the AIDS epidemics. When I went into psychiatry, I had the privilege of being trained by a kind and wise man, Professor Luminet. He showed students how to be successful, our work required trust and mutual respect. It was about working together, not a power trip. Patients had to be recognized as experts in their own stories. They knew things we did not. We knew a few things they did not. It taught me to recognize my own shortcomings, be it lack of knowledge or countertransference, even if it was embarrassing, painful, or scary. Accepting our limits and recognizing our feelings were the best way not to project them onto our patients and risk to push them away. He encouraged my endless curiosity and smiled at my unintentional impertinence. His humanistic teachings, healthy distance from scientific dogma and academic arrogance, affirmed many of my autistic qualities: honesty, sense of justice, thinking outside the box, seeing a person, a tree, before the forest, and a healthy caution for theories and generalizations. This learning came in handy when I worked with women whom my colleagues seemed to run away from and were angry at, the borderlines. I did not grasp why my peers were not interested in working with these sensitive, resilient, and very much in pain women mostly. Nothing, be it therapy or medications, seems to help them, and their risk to die from suicide was higher than for any other psychiatric population. I wanted to make a difference. My chairman suggested reading the work of Otto Kernberg, a psychoanalyst who had adapted the traditional psychoanalytical setting and technique to better work with patients challenging our traditional practices. First, we had to provide a safe, dependable, and solid environment. Same setting, a regular schedule, some form of neutrality and consistency in who the therapist was. I mean, I had to be the same person from an encounter to the other. In this case, My relatively lack of facial expression was a plus. My own inclination toward routine and dependability made the rest easy. Guess why so many psychiatrists are part of ADI? Kernberg recommended 3 steps to follow during the psychotherapeutic process. First, clarification. The therapist has to make sure to understand what the person says, feels, expresses, experiences, and has to make sure to be understood herself. Second, when the therapist has a good grasp on the patient's story, make gentle confrontations if things are not clear or experiences do not seem to make sense. Gentle is important. It is not about challenging or proving someone wrong and making a point. It is about helping to make sense of experience in the present and sometimes put it in perspective with the present or the past. Then the third practice comes, and it might take months or years, or sometimes we never go to there, and we use that knowledge to help the patient towards more careful hypothetical interpretations. Making sure I understood what the other person meant and making sure I was understood myself were techniques I had trained for my entire life because of my autistic brain that did not get these things spontaneously, in particular when interacting with non-autistic people. For the gentle confrontation and interpretation steps, I had 3 advantages, confirmed a few years ago by my spiky neurocognitive profile. I am very detail-oriented, and I have an exceptional memory for facts. I also have a remarkable ability to make connections with loosely associated data. These are some of my autistic strengths. Until recently, I genuinely and naively thought that it was the same for all psychiatrists. I was wrong. These techniques came naturally and helped me to build authentic therapeutic alliances, which are the cornerstone of success, no matter which theoretical model we use. We were working together. When I listened to my fellow Belgian colleague, Peter Vermeulen, when he described his work, for instance, I realized that even if the language we use is different than the theories, our practice shares the same purpose: the importance of trust, clear communication, and through proper contextualization, helping the patient make better sense of the world he or she lives in. Making sure we understood one another became critical when I moved to Los Angeles in the year 2000 and began working with people from a wide range of languages, cultures, and socio-economic backgrounds. From the homeless encampments and the public hospital to a private practice in Beverly Hills, very small, an essential part of my work involved translation, literal, sociocultural, and symbolic. Being aware of this translation aspect of our work as healthcare providers is a real asset when we address the double empathy problem I mentioned at the beginning of the talk. You're probably familiar with it, but I'm going to repeat it. Until recently, and still in many, many places today, when autistic and non-autistic people have trouble interacting, the autistic person alone is considered responsible for the deficit in understanding. Damian Milton reminded us that communication is a two-way street. The difficulty between autistic and non-autistic people is really about mutual understanding or the lack of it. What we need are better translation tools, because even though we are all from the same planet, we definitely are all from this planet, our minds function differently depending on our neurotypes. We are often speaking different languages, even if we use the same words, or if for some, the words are never spoken. The best way to become a translator is first to recognize that our languages are different, and second, to learn the other language. even if not in details, at least the basics. All these realizations, again, were critical when I was consulted about 10 years ago by Natalie. She was in her 50s, with a life full of pain and struggles. By that point, she had received numerous diagnoses since the age of 4. Anxiety, OCD, depression, PTSD, bipolar disorder, even schizophrenia. No therapy or medication, and she had tried them all, ever seemed to make a difference. Frustrated, the colleague who referred her to me suggested that she was borderline, willful, and did not really want to get better. It angers me so much when I hear that. When we met, she was desperate. She had a college degree, but could never be able to work full-time. She had relationships, but could not maintain them and did not understand why. Reading the notes of previous therapists and psychiatrists, it was clear that she did not fit their models. No diagnosis stick. Yet her suffering was undeniable, her anxiety through the roof, and the risk of suicide very, very real. Natalie was sincere and helpless, just as helpless, in fact, as the colleague who referred her to me. I decided to request neuropsychological testing. These tests in the United States at this point are $6,000 to $7,000. It was only the second time in my career I asked for testing. The results came back. She was obviously autistic, said the psychologist to me. I wasn't entirely surprised. Her affect was a cue, but at the same time, autism? Really? She's a woman. She's gone to college. She drives to my appointments, and she's very engaged in politics. For Natalie and her family, it was a shock. After decades of distressing labels with devastating effects on her self-image and her relationships, including with her parents, the word autism changed everything. None of my training, and I trained twice in Belgium and in the US, none of my trainings had taught me how to identify autism in adults without intellectual disabilities, especially in women or minorities. Autism was never mentioned as a possibility in the differential diagnosis for major pathologies that we were trained to recognize and treat in psychiatry. Not that we need to treat autism, I'm coming back on that, but we were not made conscious of its existence. I knew a little bit of Asperger's, quote, but it was thought to be limited to a few men and then rare. With Natalie, I suddenly realized that, like everyone else, I'd been caring for autistic patients all along, without ever knowing it. Looking back, I can see that many of the so-called borderline patients I worked with were actually autistic. The fact that we shared a neurotype explained why I felt so comfortable working with them and why they often felt comfortable with me. Their experiences made sense to me. I was not trying to trap them or shame them or convince them that they were not who they thought they were. I believed them. This is, by the way, a powerful reminder of why it is essential to build and have a neurodiverse workforce in healthcare. A workforce where neurodivergent individuals, autistic for instance, can be open about who they are without shame or fear of discrimination. Not because we can only work with people who share a neurotype, but because by sharing knowledge and experiences, we enrich both patients' care and our co-workers in ways no textbook could ever capture. We can be daily ambassadors, translators among neurotypes. The autistic lens I gained, thanks to Natalie, transformed my practice. Suddenly, the word autism took a new meaning. It opened the door to new ways of listening, of making sense, of helping others. I also quickly realized that for many patients, being identified as autistic was life-changing. It brought validation and healing, but also grief and anger for all the lost time and missed opportunities. Elizabeth, with whom I work and knew I was coming here, she authorized me to share her words about her experience as a patient late diagnosed. She wrote, open quote, about the 1,000 cuts she received over a lifetime of being an undiagnosed autistic individual, and about her frustration with what gets pathologized and legitimized under a medicalized system, one that does not fully capture the lived experience of someone on the spectrum, end of quote. Identifying autism is not only important for an individual, it can also be transformative for a couple or a family as a whole. For a couple, the realization that one or both partners are autistic can be life-changing. It helps to contextualize years of misunderstanding and pain, but also years of complicity and strength. For couples or families to be properly helped, however, it is essential that the therapist, the physician, not only understand what being neurodivergent really implies, but also act as a neuroaffirmative translator. Without that, therapy risks reinforcing whole hurtful dynamics and feeling of helplessness. I'm often deeply moved when I work with couples who have stayed together despite lacking the tools to fully understand one another's neurotype. The power of their unconditional love often brings tears to my eyes. And then the relief is profound when together we can finally make sense of so many hard to understand past behavior. Of course, not all stories have a happy ending, end quote. But even for those who decide to leave one another for separation, the fact that we can understand better why brings peace and removes shame. Last but not least, because genetics plays such a critical role in the transmission of autism, the realization that a person is autistic can change how they view their own, often complex family history. And yet, just as the word autism seemed to be emerging from the dark ages of stereotypes, new threats are appearing. A recent article from the American Psychological Association described how policy shifts in the United States have stoked fears of stigma and surveillance, like Orwell's 1984. I really recommend to everybody to reread it, where Big Brother is watching. This is not just a metaphor. Psychologists have observed a wave of autism evaluation cancellations and requests to redact medical records, and I do too. Like in 1984, words can, in the flash of a tweet, lose their original meaning and become tools of discrimination. This is why it is crucial for all healthcare professionals to provide, within the safety of their practice, accurate information about autism. Let me share some basics, and I apologize for the one who are already familiar with all this. A few basics about autism, what autism is not. It's not an illness that we can cure. It's not caused by vaccine, bad mothering, or Tylenol. That last rumor, by the way, once again placed the responsibility, in quote, on mothers for a neurobiology that is in reality generally, totally, mostly determined by genetics from both parents. Autism does not concern only young white boys. It's not only synonymous with genius, intellectual disability, or psychopathy, although, of course, it does not exclude it. And it is certainly not something you should hide from the autistic person. So what is it? It's a neurodevelopmental difference present in all populations, regardless of sex, ethnicity, or background. Autistic people do have empathy. This is extremely important, in particular for autistic people who choose to work in the healthcare profession and helping profession. One of the reasons some of the people at ADI or some students are denied access to medicine or psychiatry is because supposedly they have no empathy and no theory of mind, which is absurd. I hope you understood that. So we have empathy, and especially emotional empathy. The difficulty lies with cognitive empathy, which does not come to us as naturally. As I detailed in the beginning of this talk, we can learn it, and many of us are good students and very determined to do so. Autistic people can work, even though many struggle to find and keep jobs, especially in ever-changing systems or an environment that are overwhelming. We can have families, even if relationships sometimes present challenges, but who doesn't? We can think about what's happening in other people's minds, even if the learning curve is steep when it comes to understanding non-autistic minds. Autistic people experience the same range of mental and physical illnesses as non-autistic people. Being autistic is not incompatible with OCD, ADHD, or cardiovascular disease. In fact, these conditions often overlap. And yet, I still hear patients being denied treatment in specialized clinic, like OCD clinic, because they don't treat autism. Importantly, the autistic neurobiology must be taken into account when addressing psychiatric or medical condition. It affects how an illness is expressed, but it should not never be a reason for discrimination and exclusion. To fit in, autistic people use masking and camouflaging, in other words, trying to pass for non-autistic. And I think, by the way, that the pressure is much higher on girls than boys, and that's one of the reasons and some of the difference in our phenotypes. These lifelong adaptive behaviors need to be recognized. People must understand that while masking might sometimes be necessary to get through school or to keep a job, it comes at a heavy cost. Masking increases the risk of mental illness, burnout, and even suicide. It is not a cure for autism. We can reduce the need for masking by creating more autism-friendly environment, and I refer to a brilliant talk from Mary this morning and the space concept. At work, it can be as simple as telling a neurodivergent employee, it's fine to keep your door closed, or wear your noise-canceling headphone, and by the way, don't feel that you have to come to the office social events. This costs nothing. Remove the fear, remove the shame, save many sick days, and keep a great coworker on the team. As healthcare provider, as Mary explained, we also wanted to make our practice more accessible. This can mean allowing emails in place of phone through make an appointment. Working together means that learning has to come from both sides. But for healthcare workers in general, and psychiatrists in particular, these outdated stereotypes remain the norm. The consequences are devastating. Time and time again, I'm heartbroken and angry when I hear about the invalidations patients have endured while seeking answers about their neurodivergence. When patients needed validation, they got mockery. When patients needed compassion, they got hurt, the 1,000 cuts Elizabeth spoke about. When they should have been encouraged to put down the mask, it was shoved back onto their face. Let me share a few examples. Lisa was treated for anxiety for 10 years by a psychiatrist who prescribed antidepressants and regularly encouraged her to get out more to feel better, without much success. When Lisa realized she might be autistic, she was hopeful, thinking she finally found an explanation for her struggles. When she asked her doctor for his opinion, he laughed and reassured her, of course she was not autistic, she made eye contact. He dismissed the online information as garbage. When she came back with detailed examples from her own life, a very autistic way to persist, he grew angry and fired her, saying that he did not work with borderline. Virginia made an appointment with me after being diagnosed, she was honestly sharing with me, with schizophrenia, PTSD, bipolar disorder, and borderline personality disorder. By the end of our meeting, when it was clear she was autistic, she asked me why, out of more 30 psychiatrists she had contacted, I was the only one who gave her an appointment. Most never returned her calls or emails, and 3 said they were full. I tell you why. Many psychiatrists don't want so-called difficult patients. When someone shares an history of multiple misdiagnoses given to them by professionals, many psychiatrists and therapists see red flags and lawsuits, and they prefer not to take them on. So many patients give up. Dana called me after her 80-year-old father told her on his deathbed, literally, that she had been diagnosed as autistic as a child, but her parents had been instructed never to tell her, supposedly to protect her. The result? A life full of doubt, anxiety, and shame, and a persistent feeling of being bad and not enough. And then there is Lishar. When she asked her psychiatrist if she could be tested for autism, he told her that she couldn't be autistic because she had a family. And in any case, he added, it was too late and useless to seek a diagnosis. So much ignorance, so much arrogance, so much time lost. On the first page of his book, Beautiful Lives, Stephen Unwin quotes the Indian novelist Arundhati Roy, open quote, "There's really no such thing as the voiceless. There is only the deliberately silenced or the preferably unheard." Quality of life means having access to care, educated, thoughtful care. With more autistic adults coming forward through the media, explaining how beneficial their autism diagnosis has been, many people are beginning to wonder, could autism explain my lifelong difficulties? So why are we witnessing such an aggressive pushback from society, including from physicians, when patients raise the question? Sure, doctors are burned out, but it's not the patient's fault. And as far as I'm concerned, the more people are curious and aware of their mental health, the better. Telling people who are genuinely trying to make sense of their lives that they are not qualified to have an opinion about themselves, that is epistemic injustice, it is wrong and unproductive. The problem is not that there are too many autistic people. Autistic people exist, they are who they are. The problem is the deficit of knowledge and training about autistic individuals in our medical school, nursing school, psychology school, and continuing education program. When leaders in psychiatry, like Alan Francis, lament the broadening of autism criteria, I have to wonder, how much clinical experience do they truly have with the suffering of the people they dismiss? In a recent New York Times op-ed, Francis argued that the misdiagnosis of autism could, in quote, affect people's self-perception, self-esteem, behavior, and expectations in negative ways and haunt someone for life. At this point in my practice, I sincerely do not believe you can convince yourself that you are autistic for any prolonged period of time if you're not. On the other hand, I've regularly observed how invalidating a correct diagnosis of autism can indeed, to use this quote, affect people's self-perception, self-esteem, behavior, and expectation in that precisely negative way Francis denounced. As he mentioned in the article, if patients feel they need to remove autism from their medical charts to avoid mistreatment, the issue is not that the diagnosis should be hidden. The issue is that physicians are poorly informed, equating autism with, I don't know, whatever weirdness that make them uncomfortable and run for the door. As a clinician, my practice evolves constantly. I have to adapt if I want to remain relevant. Over 40 years, I've seen labels, classifications, and treatments come and go. I am not rigidly attached to any single name for a condition. My focus is not on classification, though yes, classification are necessary tools, mostly for research and finance. My focus is on patient care. If you want to change the name, so be it, but do not cancel us. By discrediting an entire population simply because they no longer fit outdated ideas about what autism should look like, researchers and clinicians embolden the damaging behaviors of the poorly informed colleagues I just described. Professor Francis, in fact, should be grateful. Thanks to the expanded diagnostic criteria, and in particular speaking about sensory differences, he helped establish the fact that we are now able to identify people who were previously misdiagnosed and poorly treated or underdiagnosed. For instance, autistic people who, because of catatonia, literalness, or poor eye contact, were once labeled schizophrenic, and for whom the side effects of antipsychotics were devastating. Autistic people who struggled with relationship and self-image, labeled borderline and denied proper care in shame. Autistic people with social anxiety, forced to expose themselves to loud, stressful environment in order to get used to it, an approach that does not work with our neurology. Autistic people who suffered paralyzing burnout after a prolonged period of intense focus, only to be incorrectly diagnosed and treated for bipolar disorder. Criteria and stereotype may change, but the reality of autistic neurology does not. Its specificity must be included in medical school curriculum and continuing education that we work on, as I said yesterday, for the one who were here, in collaboration with our colleagues who are not autistic, but who have a clinical experience. And we try together to see how we can learn and better understand people who are different from us. Autism is not a disease, it's a neurodevelopmental condition, but it can make us more vulnerable through a combination of genetic and environment to many physical and psychiatric problems. Autistic people without intellectual disability have an average lifespan that is 6 to 15 years shorter than the general population. The leading cause of death is cardiovascular disease, similar to the general population, which is not surprising when we remember that most of us autistic people live in a constant state of stress. The second leading cause is suicide. In the general population, suicide is the 11th cause of death. We know that more than 80% of autistic people experience psychiatric problems at some point in their life. And yet they face enormous barriers to accessing care. Because of these vulnerabilities, autistic individuals who may not look autistic enough are overrepresented across all our clinical settings. They often have a very different threshold for perceiving internal body signals like pain, thirst, hunger. And because they struggle to access and receive proper care, they are 3 times more likely to use the emergency room, to be hospitalized, and to die after receiving emergency care. 3 times. The risk is higher for autistic women, who are 3 times as likely to die during hospitalization as non-autistic women. As you heard, this talk is about an autistic population I know and I work with, people without major intellectual disability. But we are in this together. Too often I feel the divide between autistic people with different levels of needs is amplified and used to keep us from uniting and becoming stronger together. Yesterday, T.C. Weisman reminded us the importance of the village. You have to do it right to build the trust. And in the village, every person has its place, his place or her place. In the afternoon yesterday, Sue Fletcher-Watson reminded us that being different is a strength, and affirming complexity enrich research and clinical work and advocacy work. We need support for everyone. the right kind of support, telling us that resources are so limited that one population must be sacrificed for another is unwarranted. Healthcare is expensive, and this is exactly why early identification and education matter. They prevent suffering and save money. Fewer sick days, fewer chronic illnesses, fewer hospitalization, fewer deaths, more expertise, more thinking out of the box, more innovations, more advocacy. When primary care doctors, internists, OBGYN surgeons are made aware, sometimes by their patients, that autistic people are more susceptible to certain rare medical conditions, they can provide better care faster, and we all benefit from it. And most doctors, I think, want to provide better care. In the last 2 years, together with a small group of colleagues, psychiatrists, we presented 2 symposia on autism in adults and young women without intellectual disability at the annual meeting of the American Psychiatric Association. It was not easy to get our abstract accepted. Out of 250 talks given over 5 days, only 3 out of 250 addresses autism. When some research showed that 20% of patients coming to our outpatient clinic are autistic, it really pondered, but that's for another talk. Each time, we were scheduled in the afternoon of the very last day of the conference, after most people have already left. And yet, each time, the room was packed, and this year we had a bigger room, and it was packed too. Attendees were riveted. The Q&A were on long after the session ended. Our colleagues wanted to know how to better respond to the surge of autistic adults and teenagers, often self-diagnosed, coming into their practice. They were starving for good practical information. Most people want to be better at doing what they're doing. That gives me hope. We, autistic and non-autistic, all of us who work for a more informed society and more tailored care, must overcome divisions. Together, like here and now in Dublin, we must collaborate among one another, among insiders, autistic, professional, patient, non-autistic. We want to work and make sure that every autistic patient is believed and supported, especially when they have unusual presentations that we were not taught in medical school. To my colleagues, I asked, do not shut us down. Listen up. We will all be better for it. Thank you. We may have little time for questions.
We have some time for questions, a few minutes left. We have one here. Just want to come forward.
Can you not speak too quickly so I can process? Thank you.
Okay. Sorry for my English, not very good, so I will speak not quickly. You mentioned a number, 20%.
I'm so sorry, can you speak in the microphone?
Okay. You mentioned a number, 20%. Do you have, or anyone have, a number for the autistic population in the world?
I mentioned what? I'm sorry, I didn't.
Do you have an estimation for the total, the number of the autistic people in the world? You mentioned 20%.
Oh, in coming to the clinics?
Coming into the clinics, but in general.
Well,
Because in my opinion, we are at least 20%.
I think it, again, depends how we define it, right? And if we don't see that someone is autistic, they don't come because they're autistic often. They come because of other symptomatology. And if we don't recognize it, it's going to be a problem. But so they don't come into the statistic. The one I mentioned is a study in Sweden a few years ago, right? Which they say up to 19% in a clinic open to everybody, right? They did retrospective study. So I agree with you. I'm sure it's at least 20%. Some study, if I'm correct, show in inpatient, in psychiatric inpatient, maybe 30 or 40%. And I think the more we are, the more advanced the problems are, because we don't come early, for the reason we said, the higher it is. So they're a very high proportion. That's why both in our schools and the APA or other places, we need to speak more about it and inform people.
In these conditions, do you think the autism should remain undiagnostic or be removed from the diagnostic manuals?
I'm not Ellen Francis. I don't think autism should be in itself a diagnosis of a pathology. I think it influences, and I'm gay. And I think one of the advocacy I'm doing is because I experienced kind of the same, you know, you're pervert, you cannot be a psychiatrist, all that things. And that was in itself a pathology. What was the problem is that the society and the way we experience it made it worse. So I think autism can be accompanied with a lot of disabilities and genetic difference and psychiatric difference. I don't think in itself it is a pathology. I think it should be removed from the DSM, but I hope they don't take away my license for that.
Thank you.
Hi, just reflecting on the misdiagnosis that happens, especially in women looking for an autism diagnosis, whether that's BPD. It reminds me very much of the medical model of the early 20th century, and obviously in the last few decades we've moved into more of a social and integrated model society, but is there anything that you would recommend for the next stage in that change in order to include universal design for not only learning but living, to make it more practical to integrate us rather than as a separate group but as an appreciated aspect of general society?
I'm not sure I totally understand, but I think we will be successful where, in the same way I feel in, not everywhere, but in many settings, the fact that I'm gay or not doesn't matter, right? But people know what it means, and that I have a wife, for instance. The day we don't have to say, or we can say we're autistic, oh yeah, that's, you know, that's what you have your hair for. But the day nobody will care because we'll be integrated will be a great day for me, at least, you know, and for people who have different type of needs, of course, it's different. And that's why I think that I may lose my license on that too, but I really think that more people should be able to make an evaluation. I mean, we didn't, and I don't think neuropsychologists won't be the only one. I mean, we have 5 years of, imagine 5 years of wait before we can work and give you tools and all that. I think most healthcare professionals or psychiatric psychologists should be able to have a good idea and maybe refer when it's more complex, more difficult to expert. That should be part of a general training.
Maybe appreciating it as part of biodiversity rather than a separate thing altogether, do you mean?
Yeah.
Yeah, perfect, thanks.
Thank you.
Hello.
Hello.
I strongly agreed with what you said about the village and about not dividing our community. And in that context, I noticed what it said in the bio on the Congress website, that in the last decade you chose to focus on working with autistic people without an intellectual disability. Is that not such a division, dividing autistic people in having an intellectual disability or not? What are your thoughts about that? And where would you put the cutoff point between intellectual disability and not intellectual disability? Thank you.
Yeah, and I'd say that because my practical experience, you know, I want to talk about what I know and experiences, and I certainly, there's a lot of, it's one experience among many. You're right, we make kind of a division in a way to try to differentiate, you know, like I work very rarely with, and sometimes with nonverbal autistic patients because it's not my expertise, and sometimes there is nobody else, and so I do my best, but I tell them that. So there are differences, of course. That doesn't mean that we cannot advocate for some, you know, one another. I think I've been able to the word of disability in general that we are not taught at all in medical school. I mean, it's devastating to realize how ableist medicine is. I mean, sorry, I discovered that late in life, but it's incredible. So there are all these divisions. I think we need to respect, and I really mean it, genuinely, these different experiences. But we can relate. Like I said, as a gay person, I could relate it to certain discrimination that another person have, and why it's important not to be afraid of the other, where we need a dialogue. And it's not easy sometimes to have a dialogue. Sometimes you just want to yell, but if you yell, nobody's going to listen, particularly the one who need to hear. So there are differences, and that's where I say, of course, there are needs, and we need the help. I think for some time I feel the politics or the financial one divide and say, okay, it's only one pot, you know, you fight among yourself, and that's not fair. We want to do the things better for everybody. I'm not sure if I answered, but yeah.
Thank you.
Thank you.
Thanks for the presentation, it was wonderful. My question is about internalized stigma. So I do diagnostic assessments in adults in a hospital setting. So I have just a very small number of appointments to see patients within. And most patients tend to be really pleased when they get the diagnosis. They're relieved, they're validated. A lot of them know so much, a lot of them know more about autism resources than I do, and it's great. But where I really struggle are the ones who feel terrible about it. You know, somebody else has prompted them to be there. I feel like it's good for them. They don't feel like it's good at all. So how to deal, some form of post-diagnosis support in a really small time frame. And then on the personal side of that, I have a couple of young people in my life who are basically tweens, and both of them are clearly on the spectrum in a nuanced way, but definitely on the spectrum, and I think would benefit from knowing that. But their parents are very much have really bought the no way, that sort of thing. And I can't, what can I do in terms of, I don't want to intrude on their parenting, but I would really like to help these little kids who I'm close to. So that's my question.
Thank you, that's very important. I think knowledge is essential. I think sometimes if you explain to parents, so you present it. Again, I take a lot from my experience with borderline patients where I learn to share, to explain what it means at the time, what we have to work at, and how we can, people can get better, right? So I feel when we use the word, of course, there are all the stereotypes, so I may do a little bit of education, send to my YouTube video. There's a way you Google my name and autism and you can find them, and then see why it's important. So removing the shame. It's important if you have Ehlers-Danlos, and no doctor believe it, and you say, I'm autistic and I know I have more risk for that, or more risk for fibromyalgia, or not. So I had a patient with esophagitis, eosinophilic esophagitis. It's a rare gastroenterologic problem. Because she was autistic and had eating disorder in her family, the doctor wouldn't believe that she couldn't swallow. She almost died from that. And she came with the papers to the gastroenterologist, finally did the test that needed. So people being informed, it's not a stigma, it's for you to know yourself better. It was okay, yesterday I walked around with my hat because I couldn't bear the light. I would never dare to do that 6 or 7 years ago. And to come for the first aspect of your question, it is hard, right? And the longer, some patients we lost so many years, there is the shame, so it is a journey, and I imagine it's very hard when you have only one session, but when you have only one session or two, you can say it's going to be a journey, but you will be able to put this puzzle piece in place. Knowing more about yourself will help you with your couple relationship, with your family, at work, to be a better advocate for yourself. So yes, there is the anger and the regrets, and you can use that in different ways. But I'm a very practical, I say I'm a clinician, so I'm very practical. How can I help you to use that knowledge to make your life, less complicated, less painful? And also validate and recognize the pain and the shame and the suffering, of course. I don't want to say, oh, it's all great, absolutely not. It's difficult, but let's not lose more time.
Thank you.
We're out. I'll be there if you want to. Oh, one more?
No, sorry. Sorry, we've unfortunately been told we've run out of time, but if you could ask your question individually afterwards, that would be really helpful. So, just like to thank Bernadette again and show your appreciation for a fantastic talk. Thanks, everyone.